Next speaker is Dr. José Pedro da Silva. Everybody knows him, professor of cardiothoracic surgery, founding director of the Da Silva Center for Ebsen's Anomaly, and he will talk about the contemporary cone repair results and research in Pittsburgh. José.
Thank you. Okay. Okay, I start talking about a little bit of the history of Ebsen anomaly surgical treatment. That started in '58 with Hunter Lillehide design a surgical repair technique and suggest a new form of surgical therapy for Ebsen anomaly. Unfortunately, their patient was a 10 years old boy, and he died during the cardiac anesthesia. However, his work influenced many other works in the area, and Hardy in '64 for the first to do tracheal valve repair using the Hunter and Lillehide technique. And then improved the technique using the same transverse plication of the lateralized right ventricle, as suggested by Hunter, and repair the tracheal valve at the level that exists in the right ventricle. His technique favored many patients, however, it could not be performed in any anatomic subset, and they have to replace the valve in about 50% of the patients. Carpentier in '68 they started doing vertical plication instead of transverse plication, and started delaminating only the anterior and inferior leaflet of the tracheal valve without pay attention to the septal leaflet and the anteroseptal commissure area. So he didn't replace too many valves, but he had high mortality, and because he operated essentially in adult patients. And then when they did in children, they didn't have high mortality, but as the children grow, the valve started leaking, so didn't work very well. So those techniques had limitations. So in 1989, I started working a technique to treat Ebsen anomaly, and I was interested in that because I have learned the Dennison technique at the Cleveland Clinic, and I operated one patient, went fine, but the next patient, the operation didn't work well, and the patient went home with a lot of tracheal regurgitation. So I started learning it, and in '93 I had the opportunity to operate in the first patient. Basically, we delaminate the valve tissues, the leaflet, keeping only a small area for the distal attachment. And then we construct a cone, make some fenestration if necessary, and do also plication of the lateralized portion when necessary. With this technique, the results were good. The valve would coapt leaflet by leaflet, different with Carpentier technique. And this is the MRI of the patient was 37 years old, a lady, 25 years after the first cone operation. See that the image resemble really a cone, and for that reason we gave it that name, and especially for teaching purpose. As was demonstrated here, Abc anomaly has various degrees of rotation inside the right ventricle, and sometimes they end up attached at the outflow tract of the right ventricle. In the past, people like Brown stated that valve that have severely flat displacement into the right ventricle apex, or those anteriorly rotated into the RVLT, are generally not suitable for the traditional monocuspal valve repair. But with the cone repair, those valves too are possible to be repaired. You look here on the left at the echocardiogram in short axis, so you see the aorta valve, and then you see the tricuspid leaflet opening very near the pulmonary valve, right here. So I call this extreme rotation. This patient had already a gland, so when the heart catheterization and injecting the functional portion of the right ventricle, they say that it's very small and confirm this extreme rotation, some regurgitation. So we repaired this valve, and we got an excellent result, as you see in the right, with mild regurgitation. This graph shows the effect of the cone procedure in the mitral regurgitation in the first 54 patients that we did in Brazil. Compare preoperative with early postoperative at the discharge and late postoperative. In this case, it was about 40.5 follow-up, mean follow-up. And what was noticed that there was improvement at tricuspid regurgitation, and the result was maintained over time, meaning that the operation is durable and efficient. And here is a study done in Munich, and they compare the cone repair result regarding the tricuspid regurgitation with the technique they used before. It was essentially the Semine technique. And what they showed that the incidence of moderate or more than moderate tricuspid regurgitation is in red. The cone procedure is low and does not grade any bigger. And the other group say that it start low but then increase over time. The same thing is about the more severe tricuspid valve regurgitation, which clear advantage for the cone repair. So I was very happy to be invited to come to Pittsburgh in 2016, start in 2016, and work with a wonderful group. And here in this photo, we don't have everybody because this was taken in Washington, and some people were working here very hard. But now we could put another person here, my friend Xi Junyu, who also does a nice work with Abc anomaly. And talk about our production here as a group. We start doing the cone after it started. It started in 2019. And we were reading the article in Starn that he did the Starn and the Glen and the Fontaine, and did a study showing how the evolution of the right ventricle, and that after a few years there will be almost no right ventricle. So we thought that if the ventricle was big and became small at one time, it was on a reasonable size to do some repair. And based on that idea, we started doing it, and thanks for everybody for help in the decision making and supporting. And here you can see the effect of the Starn operation. This is a patient, a huge heart and immense right atrium and severe tricuspid regurgitation, pulmonary atresia. This is a case that Victor Morel did a Starn repair, and you see in the left, just 1 week after, the heart was small, and you see that the right ventricle was small in size, and this is because of low pressure, low filling pressure, immediate reduction. This happens in children, in neonate, but it doesn't happen in a little older patient. It takes longer that to happen. And by decreasing the size of the right ventricle, just stop compressing the left ventricle. So the left ventricle get a better shape, and then we can manage much better the shunt, the pulmonary perfusion, and the systemic perfusion. And also give more room for the lungs to develop. So this is the same case that later was submitted to the CON after Starn. And here in the left, you see the MRI. See if you run. Supposed to run, didn't run, but it is an almost normal right ventricle. And you see in two positions here. And here you see the flow pattern showing that 1.5 repair, so the pulmonary artery take blood to the preferentially to the left lung, but to both lungs. Well, I have some prejudice about doing patching the tricuspid valve, but after I had a patient have to replace the valve after attempting to re-repair, I did the replacement 1 year after because I attempted again, I didn't get it. So then we start using in some patient a patch to augment the septal leaflet. And now I'll talk about this paper was done, the main author was Vina Stoll, and with Luciana help, and myself and the group help. And this, by placing this patch, the goal is to make a patient that had a few less leaflet available to get the same results, to get a good valve performance. And that was well demonstrated in this paper. And here is an echo showing the tricuspid valve with patch enlargement. See, that's a little bit supravalvular placement of the patch. And you see that 6 months after the procedure, and see the valve work perfectly well. From that paper of Vina, we could see that preoperatively most of the patients had severe tricuspid regurgitation, and after the CON operation, the discharge, they had predominantly minimum no regurg or trivial regurg or mild regurg. Very few have moderate regurg and almost none have severe regurg. And then in the most recent echo, the result is still very good, even though there's some change, but the follow-up was not complete. This is another paper that we published here, and this is doing cone repair after TRICAS valve replacement. So we had the opportunity to do in three patients that type of operation. And that happened when we replace the valve, but don't remove the tissue under the valve. And just do some incision, but don't remove. And in this case, for example, we had a lady that was 47 years old. She had many operations. And the last, they implant a mechanical valve. And here you can see that it was obstructed, it was stuck, and with 15 millimeters of gradient. And it's amazing that the right ventricle has a reasonable function. And here we could see that there are some tissues there. And so we did the operation, and she had an excellent result. And this one is the first case. This is a case in São Paulo that Luciano was going to do, was doing it actually. And here you see a prosthesis, a biologic prosthesis that has some regurgitation and stenosis. It was done in a patient when he was 17 years old. Now, 5 years later, had that condition, and Luciana was prepared to replace the valve, but she noticed that there was a very good amount of tissues under the valve. So she called me, I went there, and we together did the valve. So in this year, in this echo, medium term postoperative, they have a moderate regurg, but interestingly, 12 years after the repair, there was no stenosis, just mild regurg. We did a lot of other patients. Obviously, I cannot comment on them because of the time concern, but we did the image, MRI. We did like cardiac MRI, predictor of right ventricular dysfunction of the Silva cone operation for IBC anomaly. Large right atrial size and cardiac MRI is associated with postoperative right ventricular dysfunction after the cone operation for IBC anomaly. So, on cardiac MRI. Assisting left ventricular pathology inpatient with IBC anomaly using cardiovascular magnetic resonance looking past the right heart. Multimodality imaging IBC anomaly. So many people will produce it, this one about midterm recovery and the right ventricular function and improvement of left ventricular function after the Da Silva cone procedure in IBC anomaly. And the other paper in the right, that is the cone repair allows right ventricular rehabilitation with excellent TRICAS valve function following the Starnes procedure. That done by FAS was now a resident rotating with us. And the electrophysiology papers also we have a lot of help in that area. And today I was talking to Quang Li from the Department of Cell Biology, because I think we need to do more papers, it's already work on that, but we have to expand work in the RV function and the different microscope anatomy of the myocardium IBC and the different forms of IBC anomaly. This one about the indication, the paper by Luciana, in the stage treatment of critical ill neonate with Epstein anomaly cone repair, the starting procedure. Mid-term right ventricular function and improvement left ventricular function after the Silva cone procedure in Epstein anomaly, for Epstein anomaly, and use the Silva operation to establish 1.5 ventricle circulation of this initial single ventricle palliation with the starting procedure. We also are in the process of doing many other papers, and we're doing a long-term follow-up, a longitudinal study involving a patient done in Brazil with here and also in 2 places in Brazil. And I think this will be a great paper, involve about 400 patients, and should bring a lot of information, the long follow-up of those patients. Again, here's another paper in the electrophysiology experience in 133 patients that Dr. Orloff has already commented. And this should not show because, and this is about surgical technique too. We are describing the different modification and the cone repair, how to perform the cone repair, especially the subset of patients with extreme rotation of the tracheal valve into the right ventricle outflow tract. For example, here we showed that we cut that papillary muscle related to the anterior leaflet that was very close to the pulmonary valve and mobilize it to be suture to the base, to the most distal part of the septal leaflet. And here we have the final result. And here the echocardiographic result with trivial regurgitation. And finally, as a result of that, all that teamwork, we had operate now 188 patients. Here I represent the one until May 2026, 186 patients. Most of them were children, accounting for 64%. But we did a considerable number of adult patients, to 27% of them. And infants, which is the more challenged and more risky patient, did 15 cases, and then a total of 186 patients. And we also did in 23 patients, which are included in the above, here in the Children's Hospital, and 2 more patients in Tampa, Florida. So, and about the result, we have only 1 hospital mortality, and this was a patient, adult patient, 68 years old, with other conditions that increase her risk, unfortunately. And then the total mortality was 0.5%, and we didn't lose any children or infants. Regarding late tracheal valve re-repair, we did in adult 1 re-repair, in children 5 cases of re-repair, and in infants we did 1 out of 15, and also in cone after stars, I think we did 1 re-repair as well. So altogether we did about 5%, 4 to 5% of re-repair. And then late tracheal valve, we did These are only cone repair, but in our group here in Pittsburgh, we did one trachea valve repair, but it was in a patient with a bad anatomy and especially bad right ventricle. So we are attempting to reproduce what we did in the past, put a valve and wait for the ventricle to improve. And then when we had to replace the valve, we do the cone. Regarding latent deaths, we had a few, and some of them for cardiac, but other for non-cardiac condition and causes. And the total, we had lost 4 patients till now. But we are going to study them in detail, as I mentioned before. And in the cone of the stern, we lost 1 patient, but this one patient that had need a liver transplant. And we need to repair to get in a better spot before doing the liver transplant. But the patient has also tracheostomy. So she survived the cone repair, went home, but unfortunately she aspirated. She had a complication with the tracheostomy and died at home. So we'll summarize that the cone repair is effective and durable with rare need for tracheal valve replacement, even severely rotated tracheal valves. Neonates with critical ABC anomaly can benefit from a staged approach by performing the Stern procedure in the neonatal period and then the cone repair later on. The cone repair after the prosthesis implant can be viable, and the tracheal valve leaflet were preserved at the previous procedure. Right ventricular dysfunction, the ABC anomaly, is a real problem in variable degree and need to be further investigated and for treatment improvement. Thank you very much.